endocrine gland. Okay, it is also known as hepar, and it is vase in shape. Look at here. So, and it occupies the whole of the right hypochondrium, upper part of the epigastrium, and left part of the hypochondrium. Okay, yeah, अलिकति आएको छैन. So it extends up to here also. So whole of the right hypochondrium, upper part of the epigastrium, and left part of the
This
left
call is now being
hypochondrium.
recorded.
So this is the surface marking of the liver. So it's in case of male, it is 1.4 kg, and in case of female, it is 1.2. Range it can range from 1.4 to 1.8, whereas in female it is 1.2 to 1.4 kg. Okay. So in case of liver, it has 5 surface, 3 border, 4 lobes, and fissures. Talking about the surface, it has parietal surface and visceral surface, or you can say inferior surface. So parietal surface is again divided into superior surface, anterior, posterior, and right lateral. Okay. Borders, posterior superior borders, posterior inferior border, and prominent one is inferior border. So talking about lobes, it has right, left, caudate lobe, and quadrate lobe. Talking about fissures, there are fissure for ligamentum teres, fissure for ligamentum venosum. There are group for protohepatis, fossa for gallbladder, and group for inferior vena cava. So we'll go on details about this. For first, we'll talk about the factors which keeps the liver in position. So this is the most commonly asked Viva question. So even though liver is the largest gland, how it is hold in position. So look at your vein is coming out. That veins opening into the inferior vena cava. So from liver, these small veins are hepatic veins are coming out, and these are opening into inferior vena cava. So this is the main source which keep the liver in position. After that, you have to say intra-abdominal pressures, which is maintained by the tone of the abdominal muscle. And last one is it is not so important, that is ligament of the liver. But what you people do, first you say always ligaments of liver. No, first what you have to say, that is hepatic vein opening into the inferior vena cava. After that, intra-abdominal pressure and ligament of liver. You are getting me? Hello.
Yes, ma'am.
Yes, ma'am. So first, what you have to say, hepatic vein that open in the inferior vena cava will hold the liver in position. This is the first one. Then only you have to say intra-abdominal pressure and ligament of liver. Okay. But what you do in Viva, first you remember this only. You forget both of this. Don't do like that. Now, talking about the border, look at it. This is the inferior border. So this is most prominent border of the liver. It is sharp and it separates this inferior surface from anterior and the right lateral surface. So this is a right lateral surface, and this is anterior surface, and below it the inferior surface. So this inferior border, sharp inferior border, will separate these two things. And a little to the right of the mid, it presents a nose, interlobular nose, which lodges ligamentum teres. Look at here in the inferior border. In the inferior border, you'll get the knots for the ligamentum teres. And again, what in the inferior border, you'll get the knots. This is cystic knots, which lodges the fundus of the gallbladder. So in Viva or in MCQ question, so in which border of the liver there will be group for the ligamentum teres or group for the what gallbladder? Then you have to say inferior border. Okay. So inferior border, two important things you have to see. That is, this is ligamentum teres group and group for the gallbladder. Okay. Can I move on next slide? Do you understand this?
Yes,
Yes,
ma'am.
ma'am.
Now we'll talk about the posterior superior border and posterior inferior border. Look at here. These two borders are not so prominent. Likewise, the inferior border. Look at it. This inferior border is so prominent. No, this one, the for ligamentum teres, this for the gallbladder, which I told you before. So this inferior border is very prominent, which whereas superior border and posterior inferior border is not so much prominent. So look at here, it's what is the function? This posterior superior border separate this posterior surface from the superior surface. This between the posterior superior and posterior inferior border is the posterior surface. So this posterior surface from this ear superior surface by the posterior superior border. Okay, and it is by the upper layer of coronal ligament. Look at here. This is the superior layer of coronal ligament. This coronal ligament, falciform ligamentum teres, all are the modification of the peritoneum. Okay, so this is the upper layer of the coronal ligament. So how this posterior superior border extend? It extends from the upper or superior layer of coronal ligament, then upper end of the inferior vena cava. So look at here, this is inferior vena cava, and upper end of the inferior vena cava, then it goes to the, look at it, this is left triangular ligament. So this is posterior superior border. Here, left triangular ligament is not so prominent. So this is the left triangular ligament. I'll repeat this again. So it extends from upper layer of coronal ligament, upper part of the this inferior vena cava, and the groove for the vena cava, than the left triangular ligament. Or you can see here. From here it go like this, and this is left triangular ligament. Now we'll talk about the posterior inferior border. So it separates this inferior surface. Look at it. This all is inferior surface. This inferior surface is separated from posterior surface by this posterior inferior border, and it extends from lower layer of coronal ligament, lower end of the inferior vena cava, and line which is transversely drawn. This is called caudate lobe. So from the line which is transversely drawn across the caudate lobe, and the process we'll discuss about this quadratic process and papillary process later. Just remember, this is the caudate lobe. So it passed from here, and it goes to the fissure for the ligamentum venosum. This is ligamentum venosum. Then it end in the esophageal groove. Here is the esophageal groove. Then it end in the sharp margin of the left lobe. Okay, or you can see like this. It extends from posterior lower layer of coronal ligament, lower end of the inferior vena cava. Then it passes transversely to this caudate lobe. Then it goes to the this leaf for the ligamentum venosum. Here there is groove for the ligamentum venosum. Then it goes to the esophageal impression. Then it goes to the sharp margin of the left lobe of the liver. Are you clear? Hello, class. I have to repeat this
Yes,
again.
ma'am. Yes, ma'am.
You're clear. Hello.
Yes, ma'am.
Good. Okay. Next.
Yes, ma'am.
Okay, talking about the surface, it is divided into parietal surface and the visceral surface or inferior surface. So parietal surface is again divided into superior surface, anterior surface. Look at it. This is superior, this is anterior, this is right lateral surface, and this is posterior surface. Whereas this is inferior surface. Don't confuse with posterior surface and inferior surface. When you hold this lever in anatomical position, you'll see posterior surface in the parietal surface. Only this visceral surface or inferior surface is below it. Okay, posterior surface is here. So this all will come to the parietal surface. Only the visceral, and this is the inferior surface and the visceral surface. Okay, viscera will relate it to the inferior surface, so this is known as the visceral surface. Okay, well, so surface of the liver, out of 5 surface, only the inferior surface is well defined, and it is separated by this inferior border, sharp inferior border. Where other surface you can separate in the liver, it will merge. Okay, there is ill-defined or round border. You can't separate it in. It is imperfectly separated. Look at it: superior surface, anterior surface, right surface. Whereas inferior surface, it's just below the inferior margin, so you can see the inferior surface. Now talking about the superior surface, look at it. This is the superior surface. So superior surface is convexo concavo convex. I'll repeat this again. Look at here. Convexo, concavo, concave over here, and again convex. So this is the superior surface of the liver and peritoneal relation. It is covered by peritoneum except in this small triangular area where there is the cardiac impression. And this is due to the diversion of two falciform ligament. Look at it, this diversion of this falciform ligament. This is the falciform ligament. This low in the inferior border only, it is known as ligamentum teres. Here, this is the falciform ligament. Okay, so this area is non-peritoneal, and here there is the cardiac impression. So in superior surface, what you are getting here, lungs and pleura. Here in the center is the heart with pericardium. These are separated by the diaphragm. Okay, and these are the layer of falciform ligament. What this falciform ligament will do, connects the this liver with the anterior abdominal wall. Okay, so this is the falciform ligament, coronary ligament, all are the fold of peritoneum. When you study peritoneum, you'll understand details. Okay, so this is superior surface. Now we'll talk about the right lateral surface. So this is the right lateral surface. It is convex and covered with peritoneum, and it is related with the diaphragm and 7 to 11 ribs on the right side. Okay, so diaphragm separate it from the lungs up to the 8 ribs. Okay, so up to the 8 ribs, whereas from pleura up to the 10 ribs. So it is again divided into three: upper one third, middle, and lower one third. In upper one third, you'll get right lungs and right pleura, whereas in the middle one third, you'll get costodiaphragmatic recess. Here, lungs and pleura, here there is no lungs, only costodiaphragmatic recess. And below, you'll get the 10th and 11th rib only. This is very important while taking the liver biopsy. Please remember, so that where you where from where you'll take the liver biopsy, below the 9 costal cartilage, so that you won't damage the lungs. Okay, because upper one third, here you'll get right lungs and pleura. Look at here. Then after that, you'll get the costodiaphragmatic recess only. You, if you here, and in the lower part you'll get the 10th and 11th ribs. So while doing the liver biopsy, you'll go to this space below the 9, below 8 costal cartilage in the 9, because there will be absence of lungs. Okay, so to take the liver biopsy, we'll come in detail in next slide about this. Now we'll talk about the anterior surface. This is anterior surface, triangular in outline, and right and left lobe is separated by this falciform ligament. So from superior surface, this is coming, and to the anterior surface, this falciform ligament is coming. And here you are getting 6 to 10 ribs. And the defied process, you are getting anterior abdominal wall and 7 to 8 left costal cartilage. These all are coming in the anterior surface of the liver. In Viva, we'll ask you, what are the relation, what are the structure coming on the anterior surface? Then you have to say like this. And what is the structure coming on the related in the right lateral surface? What is the structure in superior surface? We'll ask like this. In Viva, most of the time, liver is most commonly asked. Okay, so you have to hold it and you have to show all the anterior surface, superior surface, right lateral surface, and borders, and you have to say the now what are the ligaments, what are the structure related to it. Okay, now we are talking about the posterior surface. Look at it. This is the posterior surface. It lies between, I told you, posterior superior border and the posterior inferior border. Okay, so this in the posterior surface, very important structure is present, that is beer area of the liver. There is no peritoneal reflection because this is right coronary ligament, left coronary ligament. So in between this, here is the beer area. This beer in the from this beer area, liver is directly related to the diaphragm and right suprarenal gland. Okay, there is there is absence of peritoneum over here. So what is the boundary of the beer area? We'll put the pin in the beer area and we'll ask in the spotters what is this area and what is its boundary. Then what you have to say is its boundary is apex is is formed by right triangular ligament. Base is formed by the group of inferior vena cava. Upper limits and lower limits is forming by superior layer of corner ligaments, and lower limits is forming by inferior layer of corner ligaments. This is the Beer area. Look at here. Upper layer of coronary, inferior layer of coronary. This is right triangular ligament. This is group 4 inferior vena cava. Are you clear about Beer area?
Yes, ma'am.
Student,
Yes, ma'am.
hello. Why only one is speaking? What about 150 student? Oh my God. You're getting me or not? So Beer area, in this Beer area is directly related with the diaphragm. There is absence of peritoneum. So this is the boundary. I'll repeat this again. Right triangular forms the right triangular ligaments from the apex. Base is formed by inferior vena cava. Upper limits by superior of coronal ligament. Inferior by the inferior of coronal ligament. Now, in the posterior surface first word, we talk about the Beer area. Now, after that, we'll talk about the groove for the inferior vena cava. This lodges the upper part of the inferior vena cava, and its floor is pierced by hepatic vein. In first slide, it is coming from the liver and it is supporting. Okay, it's going inside this. So after that is coming the caudate lobe. Okay, this is the caudate lobe. Look at it. This is the caudate lobe. After that, coming the fissure for the ligamentum venosum. Okay, this is the fissure for the ligamentum venosum. Look at here. So, what is its important? It's give attachment to the part of mitten of this fissure. It contains the ligamentum venosum or ductus venosus. So, in spotters or in exam, what we'll do, we'll put the pin in this fissure and we'll ask what is its important ligamentum and what is its important, what it does, it loses. Then you have to say it contains ligamentum venosus and it is remnant of ductus venosus. Are you clear? Hello,
Yes,
class.
ma'am.
Yes,
And
ma'am.
please
Yes,
remember
ma'am.
this. Fissure
Yes,
for
ma'am.
ligamentum venosum. Okay, here it is in the posterior surface. It is left to the this caudate lobe. We'll discuss about this caudate lobe in next slide. After that, there is groove for the esophagus. Look at here. This is groove for the esophagus. Okay. Now we'll talk about, so what are the structure in the, what you have to talk in posterior surface? You have to first say Beer area. After that, what you have to say? Beer area, group for inferior vena cava, caudate lobe, then fissure for ligamentum venosum, then group for the esophagus. These are the structure present in the posterior surface. In Viva, they may ask what the structure present in the post office. Then you have to say all this 1, 2, 3, 4, 5. Okay. Now we'll talk about the inferior or visceral surface. Now, inferior or visceral surface. So, what is first? This is gastric impression. Okay. So here it is viscera is related. That's why it is known as visceral surface. Gastric among visceral surface, gastric impression, you'll get fundus of the stomach and body of the stomach, and you'll get the tuber omentalis or omentum tuberosity. There will be in this picture it's not clear, so there will be rounded elevation between the gastric impression and ligamentum venosus. It's somewhere between here. You'll see the tuber omentum in the liver. Okay. After that, you'll see the fissure here. You'll get the ligament. What this is tuber omentum. After that, you'll see the fissure for the ligamentum teres. This is fissure for the ligamentum teres. It loses the ligamentum teres hepatis. Okay, ligamentum teres hepatis. What you have studied in lower limb? Hmm? Keep it here. What do you have studied in lower limb? Ligamentum teres.
Femoris.
So here is ligamentum teres hepatis. Okay, so what is its remnant of the obliterated left umbilical vein? Okay, it is what is then again we'll put the pin over here and we'll ask what is this feature. Then you have to say this is feature for ligamentum teres hepatis. Then this lodges the this lodges the ligamentum teres hepatis, and what is its remnant? It's the remnant of obliterated left umbilical vein. This two should be on the tip of the tongue. So this fissure is, oh my god, this one. What about this one? Just now I have mentioned the, oh my god.
Figure of ligamentum verorum.
So don't confuse with these two. So near to the caudate lobe is fissure for the ligamentum venosum. It is a remnant of ductus venosus. Whereas near to the caudate lobe, here near to the gallbladder, near to the inferior border, you'll get this. Look at here. This is ligamentum what? Teres femoris. Oh my god. Don't confuse two. Please memorize these two. Fissure for the ligamentum teres hepatis. This is along with the inferior border. How to remember inferior border? It is very sharp. You can easily identify. And fundus for the gallbladder will be there, so you can identify the inferior border. If inferior border there is fissure, then you have to say that is fissure for ligamentum teres, and it is the remnant of the obliterated left umbilical vein. Whereas up in the upper part, near to the caudate lobe, near to the inferior vena cava, you can see the fissure that is ligamentum venosum. Are you clear about this two fissure? Please remember this two fissure. Fissure for ligamentum venosum and fissure for the ligamentum teres. Okay. This is the one of the sheer question in SPOTUS. Either this one or this one. Right? Quadrant-shaped lobe. This is called caudate quadrant lobe, and this here you will get the pyrotic part of the stomach. Obviously, if body is here and cardiac part this here, you'll get the pyrotic part of the stomach, and first part of the duodenum will lie over here, and you'll get the protohepatis. So this is protohepatis. We'll discuss in next slide. And fossa for the gallbladder. This is fossa for the gallbladder, and related with the upper surface and body of the neck of the gallbladder. After that, you'll get the duodenal impression. Duodenal impression will be here. It's above this. Okay, duodenal impression is here, and you'll get this fossa for the gallbladder. Then colic impression is here for the right colic fracture, and this is renal impression. And this is part of the right suprarenal will be over here. So in inferior surface, what are the visceral in the gastric impression, you'll get pyrotic part and bottom stomach. After that, what you have to say this is fissure for the ligamentum teres hepatis. Then you'll say quadrate lobe, quadrangular shape. Here you'll get the pyrotic part of the stomach and the duodenum. After that, what you have to say porta hepatis and fossa for the gallbladder. After that, you have to say colic impression for the right colic fracture. After that, you have to say the renal impression and for the right kidney and part of the suprarenal gland. So you have to, and we'll put the pin, different colored pin, red pin over here, green pin over here, and blue pin, whatever pin you have to recognize all these surfaces. So this is another what SPOTUS question. And in Viva also, in cross of Viva also, they can ask. Are you clear? Hello?
Yes, ma'am.
I'm going fast or you are getting it?
Yes,
Hello?
ma'am.
Okay, fast boss, huh?
Yes, ma'am.
Or it's okay.
Ma'am. Yes, ma'am.
Fast boy.
Excuse me, ma'am.
What?
No, ma'am.
I can
The gastric aims in my body fun.
pile is now. Parallel part in the quadrate lobe. Esari unsa kesari. So yeah, unsa body and pondus. After that, lower part मा चाहिँ pyloric part of the stomach र first part of the duodenum चाहिँ यसमा भयो हेलो
Yes, ma'am, boy.
now we'll talk about the porta hepatis so we'll mark this area in the spotters and we'll ask you okay so what is porta hepatis it acts as the gateway of the liver so structure entering to the liver through porta hepatis are hepatic artery. So hepatic artery will enter over here and portal vein. Okay, so hepatic artery, portal vein, and hepatic plexus of nerve that will enters from the protohepatis. Whereas the structure that will leave through this protohepatis is right and left hepatic ducts and few lymphatics. Okay, so principle of arrangement is this will be commonly asked. What is this? This is what this is hepatic ducts and hepatic artery and the portal vein. So DAV structures. DAV structure, portal vein, how it goes from before backward. From before backward, DAV. Okay. So the DAV structure will pass out, come out from before backward. Dots, artery, and vein. Okay. So what we have to say, hepatic artery, portal vein, and hepatic plexus of nerve will enter right and left hepatic ducts and few lymphatics. Hepatic artery, portal vein, and the hepatic ducts. So please don't confuse. Always you'll write hepatic vein. No, it is hepatic and hepatic plexus of nerve will enter, whereas it will leave right and left hepatic ducts and few lymphatics. Okay. Now we'll talk about the lobes of the liver. So this is the right lobe and this is left lobe. By divided into right and left lobe by the attachment of the falciform ligament, which you have studied in the anterior surface. So look at it. This is falciform ligament anteriorly and superiorly. This falciform ligament is coming like this, and it is related superiorly and anteriorly. And by the fissure of ligamentum teres inferiorly and by the fissure of ligamentum venosum posteriorly. So look at here. This is ligamentum venosum, fissure for ligamentum venosum. This is fissure for ligamentum teres, and anteriorly is the superiorly is falciform ligament, anteriorly also falciform ligament. So this divides the liver into right lobe and left lobe. Okay, anteriorly and superiorly falciform ligament, whereas towards the inferiorly it is by the ligamentum teres and posteriorly by the ligamentum venosum. This is this is the view from posterior side inferiorly. So please look at it. This crowded loop. This is the this is the inferior border. It is view from the posterior side. This is anterior view. Okay. Now we'll talk about the this caudate lobes. Okay? This caudate lobe, look at it. This is caudate lobe, and this is the physiologically left lobe. Okay, so this is caudate lobe, and this is caudate lobe is bounded. We'll put the pin over here, and we'll ask the boundary. Then what do we have to say? As this is view from the posterior. So when you look from posterior, what you see, this is right side and this is left side. So always remember inner vena cava. As we have seen this from inferiorly, so it is looking towards the left side. But actually, what is this? This is always towards the right side. You are getting me? As you view the liver from inferiorly, so it looks like it's the left side. Left side. But actually, what is this? This is right side. Okay. As we are viewing this liver from inferiorly, so it's look like as in the left side, but it is right side. So what is this? This caudate lobe is bounded in the right side is inferior vena cava. So inferior vena cava is always in the right side. This is the right lobe, this is left lobe. So this is inferior vena cava. In the left side, what is you are getting is the fissure for the ligamentum venosum. And above is posterior superior border, which we have posterior superior border, and below is porta hepatis. Are you clear? Hello, class. As
Yes, ma'am.
as we view the liver from inferiorly, so it is looking as it is towards the left side. No, but what is this? Actually, when you turn it in the anatomical position, you'll see this in the right side. So always put inferior vena cava in the right side. Okay. So what is the boundary of this caudate lobe? This groove for the inferior vena cava on the right side. Left side is fissure for the ligamentum venosum. This one is more clear. Now above is posterior inferior border. Look at it. This is upside down. So this is inferior border. And what is this below is protahepatis. Are you clear about this? Boundary. Okay.
Yes, ma'am.
Please response. So below by the protahepatis. So yeah, we'll put the pin over here and you have to write all these boundary. So this caudate lobe is connected to the right lobe of the river by the process that is called caudate process. You can't see clearly, but this is the caudate process. From caudate lobe, there is one process coming that is called caudate process. Via this caudate process, this caudate lobe is connected to the right lobe. Okay. Whereas in the left side, there is one process that is called papillary process. So, in summary, what you have to say, this caudate lobe in the right side, you'll get the caudate process, whereas in the left side, you'll get the papillary process. You are getting me? What I've said? So, it is connected to the right lobe of the river by tail projection called the caudate process, which arises from the lower end of the right margin of the caudate process just below the protahepatis. So, if this is caudate lobe, here is caudate process, and here is papillary process. So towards the right side is towards the right side is
How did process?
and towards the left side is the papillary process. Please don't confuse. In Viva, most of the time you do the mistake. Right side going is caudate process and this is caudate lobe, whereas small is papillary process. Now we'll talk about the quadrangular shape. Look at it. This quadrangular shape lobe is the quadrate lobe. So always remember when you view from lower, C is above and Q is below. In alphabet also C come first and Q come last. So don't confuse with these two lobe. Okay. And always remember next to the inferior vena cava is caudate lobe, whereas next to the gallbladder is the quadrangular quadrate lobe. Okay. But most of the time students get confused. When we put pin over here, they say quadrate lobe. When we put pin, they just do vice versa. Don't confuse. So what you have to remember, you have to see this gallbladder and inferior vena cava. Okay. So this caudate lobe belongs to the left lobe and it is quadrangular in shape. Its right side lies the fossa for the gallbladder. I'm again telling you as we are viewing this from inferior surface, so you seems like this is left, but this is actually right. Okay, so this is right for the fossa for the gallbladder. Now left side, left fissure for the ligamentum teres. Now above and behind is protahepatis and caudate process. Below and in front is inferior border of liver. Okay, I'll repeat this two lobe again. Talking about the caudate lobe, right side, inferior vena cava, left side, fissure for ligamentum venosum. Whereas talking about quadrate lobe, right side, fossa for the gallbladder, left side, fissure for the ligamentum teres. And talking about superiorly is posterior superior border and below is protahepatis. But here, above is protahepatis, below is inferior border. Most probably you understand this two lobe and boundary. Yes or no? Hello?
Yes, ma'am.
Are you clear? If not, I'll repeat. Everyone.
Yes, ma'am.
Okay, I'll move to next slide. Relation of the quadrate lobe, what I told you, in quadrate lobe you will get the pyloric part of the stomach and first part of the duodenum, and free right margin of lesser momentum coming from here to the here. Okay, and transverse colon also, sometimes transverse colon also. So they'll pick up in the Viva, they'll pick up this, and they might ask you the boundary, they might ask you the relations. Okay. So another is radial slope. Look at your in this figure. This spelling is mistake. Actually, it should be RIEDL, radial slope. So it is the sometimes presents or really presents. It is tongue-like projections from the right lobe of the liver to the right side of the gallbladder and inferior to the costal margin. So it is occasionally presents, not every time presents. Okay, radial slope. You're getting me? So, extra lobe is present in the tongue, that is called radial slope, and it is the projection from the right lobe. Okay, it is the inferior projection from the right lobes. Are you clear? Hello,
Yes,
class.
ma'am. Yes,
Yeah.
ma'am.
This is extra lobe. Maybe in BD Chaurasia it's not written. Write it down. Okay. RIEDL, radial slope. So it doesn't cause any abnormalities, but it is just rare and it's sometimes present. Okay. Now talking about the ligaments of liver. So all these are the peritoneal ligaments. So this is falciform ligaments. This is coronary ligaments, superior coronary ligaments, inferior coronary ligaments, right triangular ligaments, left triangular ligaments, and you'll get lesser momentum over in this group also. And true ligaments are ligamentum teres hepatis and ligamentum venosus. Okay, these are false ligaments and these are true ligaments. So these are the ligaments of liver. So sometimes they'll ask you the name of the ligaments. Okay. Now first, what you'll talk about the falciform ligament. Look at here. They are sickle cell peritoneal fold consisting of two layers. It connects the liver to the undersurface of diaphragm and anterior abdominal wall up to the umbilicus. So this falciform ligament, when you cut the anterior abdominal wall, you can see this connection and you'll cut this falciform ligament. Okay, while doing the dissection, you can see this. While separating, while taking out the liver, also you have to cut this. Then you can remove this from the anterior abdominal wall. So this falciform ligaments will connect the anterior abdominal wall with the liver and the diaphragm, and has convex margin attached to the diaphragm and anterior abdominal wall. So this is convex margin attached to the diaphragm, this to the anterior abdominal wall. And its free margin, this falciform ligaments free margin extend from umbilicus to the inferior border of the liver at the interlobular node, and it contains the ligamentum teres hepatis. Okay, this free margin of the falciform ligament you'll contain in the inferior border is the ligamentum teres hepatis. Okay, now talking about the coronary ligaments, it consists of two layers, upper layer and lower layer, and between this lies the beer area of liver. We have discussed this in previous slide. Okay, so this is upper layer of coronary ligament, lower layer, and in between this is the beer area of the liver, which connects the beer area with the diaphragm directly. Now we'll talk about the right triangular ligament. Sometimes we'll put the pin in the right triangular ligament also. So it connects the right lateral surface. Look at it. This is right triangular ligaments. So it connects the right triangular. Here is right triangular. It's right triangular ligament. So it connects the lateral surface of the liver to the diaphragm and forms the apex of the beer area. So it is forming the apex of the beer area. So we can put the pin and we can ask the question. And sometimes in MCQ also they are asking this. Now, similarly, left triangular ligaments. Look at your left triangular left lobe. So, left triangular, this is coronary ligament. So, left triangular ligament, it extends from upper surface of the left lobe of the diaphragm. Okay, so this is the left triangular ligament. Now, classification of liver. Hello, class. You are monotonous or you are getting it? You are exhausted or not? Hello? बुझिरहेछ? You are understanding or not?
Yes,
Yes,
ma'am.
ma'am.
I have to repeat the previous slide. Hmm? Hello?
No, ma'am.
Yes or no?
No, ma'am.
No, ma'am.
No, ma'am.
सबै बुझेको हो?
No, ma'am.
ओहो
Yes,
कस्तो
ma'am.
बुझेको एकैछिनमा बुझ्दो रहेछ तिमीहरूले हामीले त कति पढ्नु पर्थ्यो
Ma'am, repeat, please.
Which one? Oh, I have to repeat.
No, ma'am. Ma'am.
Okay, then I'll ask you the question.
No, ma'am, we have to repeat.
You have to repeat. Okay, from where? First, don't tell me from first. Which one? Hello?
तपाईँले पढाएको तर हामीले पनि त्यो रिभिजन गरेपछि मात्र ट्याब्समा बुझ्छ भन्नु खोजेँ मात्रै
त्यो त हो नि obviously आफूले नपढी कहाँ बुझ्छ होइन if any slide you have to repeat I can repeat this you have to remember main area beer area group for inferior vena cava caudate lobe quadrate lobe fissure for ligamentum venosum fissure for ligamentum teres what are the remnant of this everything important thing you have to remember and you have to see the gastric impressions all this report diabetes what are the factors holding it is positions okay now we'll talk about the classification of liver. So it has anatomical lobe, that is anatomical right and anatomical left lobe. Physiological right and left lobe and there is Counard classification which divides the liver into 8 lobes. Okay. So talking about anatomical lobe, this is demarcated in front and above by the attachment of the falciform ligament. So this falciform ligament divided into right lobe and left lobe. Below and behind by the ligamentum teres, fissure for the ligamentum teres and ligamentum venosus. So fifth sixth of the liver is formed by the right lobe and 1/6 is formed by the left lobe. So you have to remember falciform ligamentum, ligamentum teres hepatis, and ligamentum teres venosum. So this will divide this anatomical lobe into two, okay, right and left. Similarly, physiological right and left lobe, and it is also known as cholecystophenocable line. As it extends from, it is the imaginary line which extends from the floor of the this what fossa for the gallbladder and to the groove for the inferior vena cava. There is an imaginary line that extends from the floor for the fossa of the gallbladder to the groove of the inferior vena cava. This line will divide it into right and left. So it can be divided into right and left functional lobe on the basis of distribution of the uh, intrahepatic distribution of the hepatic artery, okay, and portal vein and biliary ducts. So, along with the distribution of this tree, this is divided into two functional lobes. And on the anterior superior surface, it passes little right to the falciform ligament. So, this physiological lobe will passes from here and little right. So, it will goes from here to here. So, it is little right to the falciform ligament. Okay. So what you have to remember is physiological lobe. In anatomical lobe, it is divided by falciform ligament, whereas in physiological lobe, it is divided by the imaginary line which extends from fossa of gallbladder to the inferior vena cava. This line will demark the physiological lobe, and that is called cholecystosphenocaval line. Okay? Again, this physiological right lobe is divided into anterior lobe and posterior lobe. Okay, it is divided into anterior and posterior. The figure is not clear. Look at here. This right is the again right lobe. Look at here. It's again divided into anterior lobe and posterior lobe. Whereas this left lobe is divided into again medial lobe and lateral lobe. and the portion of each branch from a segment. So in physiological lobe, what you have to say is it extends from fossa of gallbladder to the inferior vena cava. So it is divided into right and left, and again this right and left is divided right into anterior and posterior, whereas left into medial and lateral. Okay, do you understand? Hello, class.
Yes, ma'am. Yes, ma'am.
So, so again, this right lobe is divided in the anterior and posterior and left into medial and lateral. This is again MCQ question, okay? Please remember. Thus, what anterior right lobe present anterior and posterior segment, whereas left present medial and lateral segment. So there are altogether four segments: anterior right and right posterior, whereas left medial and left lateral. Now this is very, very, very important. Cownard classifications. Okay, so what Cownard has done, he has divided the liver into 9 functional independent segments. So each why independent segment? Because each segment, look at here, this is 9 segment. So 9 segment has its own vascular inflow and outflow and biliary drainage. So it has its own one segment consists all of these three: portal vein, biliary duct, and hepatic artery. So in the center of each segment, there is branch of portal vein, hepatic artery, and bile duct. So in the periphery of each segment, there is vascular outflow of the hepatic vein. So hepatic vein will be peripherally present, but in each segment there are three contents. So portal vein, bile duct, and hepatic artery. Okay. So Cownard has classified the liver into 8 segments, and each segment gets this portal vein, hepatic artery, and bile duct. So division of the liver is independent units. So it is one unit is independent because it consists of independent three things, and that segment can resect it without damaging the remaining segment. So the segmental resection undertaken to remove the disease part. If this part is disease, this segment is removed. But the another segment is not hampered. Okay, only this segment is removed. So resection lines are parallel to the hepatic vein, leaving the portal vein, bile duct, and hepatic artery intact. As I told you, each segment consists of this portal vein, bile duct, and hepatic artery. So if we cut one segment also, it doesn't hamper order. You're getting me? So this is the independent unit. So Cownard divides this into the 8 segments. So how to count this? So first, what you have to put in the counted lobe, you have to number like 1. After that, you can go, this is 2, this is 3, and in the this is quadrangular shape, counted lobe, you have to say 4. After that, you go to the 5, 6, 7, 8. Okay, so you have to count like this. So 1 in the, please remember this one in the caudate lobe, and you go like this: 2, 3, and 4 in the quadrate lobe, and after that 5, 6, 7, 8. So this is the division of the Cownard, and this is anterior view, this is posterior view. So if one segment is which segment is disease, you can take out easily because it is independent unit. Now blood supply Cownard classification. Hello class. Excuse me.
Yes, ma'am.
So please remember this one. You have to put 1 in the caudate lobe and 4 in the quadrate lobe. Okay, then you go like this. Now blood supply 20% by the hepatic artery, 80% by the portal vein. Okay, look at here. This is portal vein. This is hepatic artery. 20% by only hepatic artery, 80% by the portal vein. Both artery and vein divides into, look at your right branch and left branch. Look at it, both is dividing. So both reaches the hepatic sinusoids. Look at here, it's forming the sinusoids after passing conducting the portal canal. So it will go here and it form the sinusoid. Hepatic arterial blood mix with the portal blood and mix in the sinusoids. Look at it. This hepatic artery and portal vein form the sinusoid and the blood is mixed over here. And this is the portal hepatic vein from which it will drain out. So hepatic artery, this is the blood supply. And venous drainage, as I told you, this vein, hepatic vein, and it's all from its part, it's coming and it is draining in the inferior vena cava. Now we'll talk about the lymphatic drainage. So there are two sets. Superficial set run on the surface of the liver beneath the peritoneum and drain into the caval lymph node, inferior vena cava somewhere. So around the upper part of the inferior vena cava, and some will go to the nodes of porta hepatis and ciliary lymph node, whereas deep set drain into the hepatic lymph node and caval lymph node. Venous drainage is not so much important. So from nerve supply, hepatic plexus which contain both sympathetic and parasympathetic. Okay. Now applied. So inflammation of liver is hepatitis. Because of the great vascularity, hematogenous spread of the cancer can occur over here. And refer pain, this is very important, towards the right shoulder because of the phrenic nerve and supraclavicular nerve. Okay, so because of the same nerve, this refer pain can be occur in the shoulder. And see what is cirrhosis of liver, progressive destruction of the hepatocytes, and that is replaced by the fibrous tissue or fibrosis of the liver occurs because of the excessive intake of the alcohol. Okay, this causes the cirrhosis of liver, and this is hepatomegaly. And as I told you in the first slide, liver biopsy is done. Okay, it is a common diagnostic procedure to obtain the small piece of liver. So where it is done in the nine. You can say don't say eight. It's the nine below the eight in the nine intercostal space in the mid axillary line, with the patient holding his breath in full expiration to reduce the size of the postdiaphragmatic recess, so that the lesion to the damaging of the lungs is prevented. So in full inspiration, what will happen? Lungs will move above and you can directly goes to the below the 8 to 9 intercostal space. There will be no lungs and you can directly go to the liver. Okay. So cirrhosis, I have talked about this, and hepatitis, it is the inflammation of the liver. Okay, this was about liver. Any question? Hello, class. Are you there? Hello.